Good evening. A warm welcome to all participants of this YouTube live program. I am Dr. Anil Kamath. I am a consultant surgical oncologist at Apollo Hospital, Bannerghatta Road. So, let me just start with a question. We know that all cancers are bad, but among these, which do you all think is the worst cancer? Which is the worst cancer of all? Now, before letting you all know the answer, let me just tell you why I would say it's the worst cancer. First, it is not easy to detect, especially in early stages. Very few of cancers of this one get detected in an early stage. Even when it is diagnosed, the treatment is not simple. In fact, it is one of the extremely complex treatments that is required for this particular cancer. Then, unlike some cancers like say cancer of the breast, where many treatments are available, here not many treatment options are there. And even when you do treat, recurrences are very common. And when recurrences happen, the patients do not survive very long. So if we take the overall number, out of 100 people diagnosed with this cancer, only about 8 to 10 people are alive at the end of 5 years. And in later stages, it can cause extreme pain and distress to the patient. So you can see that this particular cancer, at every step, be it detection, be it treatment, be it recurrence, at every step it is one of the worst. So which cancer are we talking about? So as you all know, today we'll be talking about this particular cancer, pancreatic cancer. So one of the worst cancers in this thing, which because of the reasons I told. And November being Pancreatic Cancer Awareness Month, we are having this program to raise awareness about pancreatic cancer. So it's not a very common cancer. If you see among the different, this one it would not qualify as even in the first 2 or 3, whether be it in males or females. But why it is important, when you take cancer mortalities, people dying because of cancer, pancreatic cancer comes high up there, maybe 3rd or 4th on the list. If you take the number of people dying because of cancer, and many famous personalities, some of these you may recognize. One is the founder of all the iPhones that we use, and Steve Jobs, and many other famous. The second is Pavarotti, a famous opera composer, a famous Hollywood actor, Patrick Swayze, and Irfan Khan, who later recently died of these cancers. Again, not all belong to the homogeneous group of pancreatic cancer. Some of them had neuroendocrine cancers. But what was common to all these people was most of these people did not touch 2 years from diagnosis. So that is the thing about pancreatic cancer. Very dangerous, very aggressive. So before going into this one, a few words about where pancreatic cancer is located. So it is located in the upper abdomen, behind the stomach. So this location makes it a little silent area where the symptoms do not manifest very fast. And you all can see the picture. So there is a common opening for the bile duct and the pancreatic duct and into the duodenum. So when the cancer is there, it can manifest in different ways. One, the pancreatic duct can be blocked, leading to pain. The bile duct can be blocked, leading to jaundice. Or sometimes when it grows to a big size, the duodenum blockage and vomiting can manifest. So these are the various this one. And in terms of location, we all know that pancreas is divided into various parts. Now most of the cancers are in the area marked as H, or that is the head of the pancreas. So almost 60% of the pancreatic cancers occur in the head of the pancreas, and lesser number will be at the body and the tail of the pancreas. So how do the patients present with? Like I said, it's a relatively silent cancer, so symptoms don't come. Why does it occur? Before going to the this one, let us speak a few words about what are the risk factors of pancreatic cancer. Smoking, which is a common cause for many cancers, including oral cancer, lung cancer, esophageal cancer, bladder cancer, is even a cause for pancreatic cancer also. And essentially, pancreatic cancer happens in older aged people. Most of the patients we treat are above the age of 60. Those patients suffering from chronic pancreatitis, that is repeated inflammation of the pancreas, are at increased risk of developing pancreatic cancer. Some less common this thing is high cholesterol diet, alcohol, and obesity. These are less common but increase the risk for pancreatic cancer. In terms of symptoms, many patients that we see come with non-specific pain abdomen. They complain of upper abdominal pain. Some of them say that they have been losing weight for the past few weeks or months, and they are losing appetite. They are not eating like before. So these are the common ways of presentation, which I am sure first they would go to a local practitioner, and initially an ultrasound would be done. But ultrasound it's relatively difficult to pick up pancreatic cancer because it's located on the back side of the abdomen. Some other patients present with more obvious symptoms, the most obvious being jaundice. But jaundice, there are many other causes of jaundice like hepatitis and all. Pancreatic cancer is one of the less common causes of jaundice. But if the patient has symptoms of obstructive jaundice manifests in terms of itching, and the stools are not yellow in color, they are white in color. So these symptoms with the jaundice should raise the suspicion of obstructive type of jaundice, which in an elderly patient usually means gives the possibility of a tumor being there. So these are the common symptoms with which pancreatic cancer presents with. Now, as I told, it is one of the cancers which are difficult to diagnose early. This is because patients come to us late because the early symptoms are non-specific. So we can't attribute abdominal pain to pancreatic cancer. It is one of the less common causes. So when the pain is repeated and in the same area, and when we do investigations, then we find out. And some symptoms, even when patient has symptoms like jaundice and all, there are many other causes. So pancreatic cancer symptoms overlap many other this one. And all this is because of the location of the pancreas, which is behind the stomach and in a relatively hidden area. So usually once the patient is suspected for pancreatic cancer, we do a number of tests. By this time they are usually referred to a specialized center or a cancer center. So the first thing that we do is the blood test. We do the liver function test, which is very easily available everywhere. And what we find in the liver function test is that the bilirubin levels are raised because of the jaundice. And the other thing that we look at is raised alkaline phosphatase. Alkaline phosphatase is an indication for obstruction. So those cases which have raised alkaline phosphatase, there is increased possibility of obstructive jaundice, and that being a pancreatic cancer. We do a tumor marker known as CA19-9. In quite a few cases, we find that CA19-9 is elevated in case of pancreatic cancer. So once these things is there, like I said, ultrasound is not a very good test for detecting pancreatic cancer. Usually we order a CT scan or a MRI. CT scan should be with the contrast, with both IV and oral contrast. And CT scan in most of the cases is good enough to diagnose a pancreatic cancer. Most of the time the radiologist will be able to tell us that there is probably a mass in the pancreatic head. And once the diagnosis or suspicion is there towards cancer, the next step, next test which we order to assess the spread elsewhere is a PET scan. PET scan is usually what we call combined with CT scan, so it will be a PET CT. So once we do PET scan, we have some information about the local area also, and some assessment as to how much this cancer has spread. There are other newer tests, especially one that you should know about is EUS, or endoscopic ultrasound. It is to be used selectively. Generally we don't use it in all cases, but when sometimes we need more clearer this one rather than do an ultrasound from outside, attaching the ultrasound probe to the endoscope and doing it from inside gives us more information about the pancreas. And there are the endoscopic person who performs the endoscopic ultrasound will also be able to take targeted biopsies from the lesion. The other tests which are done not very commonly is a ERCP, in which biopsies can be taken from inside the bile duct. So these are the common tests that are performed for pancreatic cancer. Normally it is liver function test, serum CA-199 and CT scan of the abdomen. Now, most of the time the question is whether a biopsy is indeed needed for a pancreatic cancer. Many times CT scan may tell us that there is a mass in the pancreatic head which is more in favor of a cancer. Do you really need a biopsy? Because performing biopsy in this region is difficult. It's not easy for a radiologist to target this lesion and do a biopsy. Nowadays we have the easier method of doing an endoscopic ultrasound and taking biopsies. There are both proponents who say a biopsy should be done and those who tell that it is not required. Those who tell that it is to be done, the points that they raise are that it helps in a clear diagnosis, especially since the treatment is quite complex. It always helps us to have a clear diagnosis so that we can discuss with the patient with more confidence and more reliability. And the second reason that they give is that though the most common type is pancreatic adenocarcinoma, sometimes it can be other forms of cancer in which the treatment might be somewhat slightly different. Rarer form of cancers like neuroendocrine carcinomas or rarely lymphomas, these are also possible. And the third point that they tell is that surgery for pancreas, which I will be talking about later, is extremely high risk. So when you are subjecting the patient to such a high risk procedure, it would always be good to have a biopsy at hand. And those who tell that it is not needed, they tell this because the imaging is more reliable than biopsy. So even if the biopsy says that there is no cancer, it might be what we call a sampling error. The needle might not have touched the lesion, or the amount of material which we get might not be sufficient to give us a clear diagnosis. So a negative biopsy does not rule out a cancer. And they say that most of the time the biopsy, whether it is positive or negative, rarely changes the management plan. This is because when the imaging is suspicious, we might suggest the patient surgery if it is an operable type, irrespective of the biopsy result. So, and the biopsy carries some amount of risk of bleeding because we have to pass through a good number of abdominal organs, and pancreas being close to the major vessels like the portal vein and the superior mesenteric vessels, it carries some amount of risk of hemorrhage. Generally what we follow is that most of the times if it is a very clear-cut case on imaging and there is no other this thing, then we proceed without biopsy. But when there is suspicion, say a patient having chronic pancreatitis with the mass, which could either be an inflammatory mass or could be a malignancy, in these cases we more tend towards biopsy. So we take a decision based on the other evidences whether a biopsy is required or not. Now, once we reach a diagnosis, the next thing is the stage of the disease. Like any other cancer, it is divided from stage 1 to 4. 1 being a cancer which is confined to the pancreas, small in size. Then comes the intermediate cancer, this one where the cancer is either big in size or it has spread to the nearby lymph nodes. And then we have the stage 4 cancer where it has spread to far off organs like liver or lungs. A PET scan will help us determine where all the cancer has spread. The prognosis again differs depending on the stage of the cancer. Stage 1 and 2 have a higher chances of cure, and these are mainly treated with surgery. In stage 3, a combination treatment might be required, surgery along with chemotherapy, radiation. And stage 4, the curative treatment is not possible. So in these cases, we advise for palliative or symptomatic treatment. Depending on what symptoms the patient has, we will try to alleviate that particular symptom. Cure is not possible. So let us concentrate on stage 1 or stage 2 cancer, where the cancer is confined to the pancreas. Not many cancers are detected at this stage, but we do get cancers which are in this thing, and here the prognosis is much better as compared to the advanced cancers. So here the main treatment is surgical. And many of you must have heard the name Whipple's operation or Whipple's pancreaticoduodenectomy. So this is the surgery which is done for most pancreatic cancer, which are located in the head of the pancreas. The head of the pancreas is in close relation with the duodenum and the bile duct. So very often you can't just remove the pancreas. You have to remove the pancreas along with the bile duct and along with the part of the duodenum. And once you remove that, then it has to be reconstructed. And the reconstruction is usually done as is seen in the second picture by bringing up the small intestine. So normally there are three joints. One, the pancreas with the intestine or a pancreaticojejunostomy. The second, the bile duct with the intestine or a hepaticojejunostomy, and the stomach with the intestine or a gastrojejunostomy. So three joints are there. Now, why Whipple's operation is famous is because it is one of the most complex operations which is done by surgeons. So it requires quite a long time. Usually the average operating time may be 4 or 5 hours, and the expertise which is required is considerable. It is not everyone's cup of tea. So lot of practice and lot of training is required before this type of operation is done. And when the operation is done leading not done in a proper way, which can lead to complications, it causes lot of morbidity and mortality. If there is leak from any of these anastomosis, especially the pancreas with the jejunum or the pancreaticojejunostomy, the pancreatic juice starts leaking into the abdomen, and this is a digestive juice, so it starts digesting the nearby organs including the blood vessels, and the patient may suddenly have large bouts of blood vomiting once the blood vessels are eroded, and can die very suddenly. So the morbidity which is caused by this type of operation is considerable, and it is an operation which is to be done by a specialized team. So as I said, early pancreatic cancer, always the role of surgery is very important. But as we go towards higher stages, especially stage 3, only surgery is not sufficient. Even after surgery is performed, we find that many of them recur, and most of them who recur so within 6 months to 1 year. Very short this one. After undergoing a very complex operation, the recurrence is within a short period of time. Chemotherapy has been used for pancreatic cancer after surgery, especially in higher stages. It has found to be beneficial, but the amount of benefit may be just a few additional months. When it comes to metastatic cases, chemotherapy would be the main treatment here, because we can't cure the disease. We are only looking at keeping the disease under check. So here chemotherapy is the main thing. But after surgery also there is a rule, and some patients might be advised chemotherapy. Now what has been changing is in the recent years is that the same chemotherapy which was being given after surgery is now sometimes given before the surgery, so that the patient can tolerate it better. After surgery, generally the patient becomes weak. He may not be able to tolerate the chemotherapy. So the same chemotherapy is given before surgery to reduce the size of the tumor and make the operation more easy. The same with radiation also. Radiation is sometimes given before the surgery, depending on the situation, to reduce the size of the lesion and make the operation more easier. This is the way recent trials have been what the recent trials have been focusing on what we call neoadjuvant chemoradiation. This is true for more locally advanced pancreatic cancer, which have spread to nearby areas or are too large to be operated directly. A word about the pathology of pancreatic cancer. Like I said, most of them are adenocarcinomas, and these are the ones which are most dangerous. But not all of them are adenocarcinomas. We have some less common pancreatic cancer, and important among them are neuroendocrine tumors or islet cell neoplasms. Some of these secrete hormones. So patient may have a stage of increased insulin secretion or insulinoma or glucagonoma. These are produced by the endocrine cells. We know pancreas has two functions. One is endocrine function. It produces the hormones, most important of which is insulin and glucagon. So tumors of these endocrine cells produces insulinoma and glucagonoma, and the other is the exocrine part, or which produces the digestive juices and all. This usually is the ductal adenocarcinoma. Some of them may present as cystic tumors or cystic neoplasms. Important among these are what we call SPEN, or solid pseudopapillary tumor, or IPMN. Metastasis to pancreas, extremely rare. We get every now and then, once in a way. The one difference that we should know about is that when we talk of pancreatic cancer, we have a near door neighbor, which is the bile duct. Now, the cancer of the terminal part of the bile duct is usually called a periampullary cancer. Now, periampullary cancer and pancreatic cancers are next door to door, very close by. But the prognosis is very different. Periampullary cancer, being in the bile duct, manifests very early because it produces obstructive jaundice. Most of it is detected at a very early stage, and the treatment results are very good. In an early stage periampullary, the cure rates are almost 70 to 80%. Whereas pancreatic cancer, even though just a few centimeters apart, carry a very different prognosis. Because not many patients are alive at the end of 2 years, and 5-year survival for pancreatic cancer is abysmal. So, not all patients who develop obstructive jaundice have pancreatic cancer. There is another cancer known as periampullary cancer, which arises within the bile duct or within the duodenum, and here the prognosis is far better than a pancreatic cancer. So, let me just summarize what I have told. Pancreatic cancer, one of the most dangerous cancers, luckily not very common, but it carries a very for those who are affected by it, it carries a very high mortality rate. Most of the patients don't come early because the symptoms are very non-specific. They come quite late. The common test which is done to diagnose pancreatic cancer, apart from the blood test, is a CT scan. In early stages, surgery is the main treatment. The operation which is done for cancer of the head of the pancreas is known as the Whipple's pancreaticoduodenectomy. In higher stages, after surgery, we use chemotherapy and radiation. Nowadays, depending on the stage, we might decide to use it before the operation. And for those patients who can't be cured, we have to look at palliation. Sometimes the palliation may be in way of placing a stent to alleviate the jaundice. Or sometimes we have to go for nerve blocks because patients tend to have severe pain. We do what is known as a celiac plexus block. So this is the general information about pancreatic cancer. Everybody should know about this cancer so that you all can tell your patients or relatives about how it is treated. Thank you very much.
So we do have question.
Yeah.
Dr. Shrikant Rao.
Yeah, Shrikant. Yeah.
What is relationship between pancreatic cancer and alcohol? What is the pathogenic mechanism?
Yeah. Now, alcohol is a risk factor for pancreatic cancer. Like we know, alcohol causes inflammation of the pancreas, what we call as pancreatitis, and sometimes there will be acute pancreatitis or severe pain, which will last for a shorter duration. But those who chronically abuse alcohol might go to a stage of chronic pancreatitis where the pancreas is completely destroyed, and this leads to repeated attacks of pain. Any inflammation in the pancreas which happens repeatedly leads to a risk for cancer. This repeated inflammation of the pancreas. So alcohol is a risk factor for development of both pancreatitis and later on pancreatic cancer. So though there is no direct causation, it's more related due to the pancreatitis inflammation, which can lead on to cancer.
So Dr. Shrikant wants to tell us something about MRCP, ERCP in pancreatic cancer.
Yes. Yeah, that is important. I did not tell about MRCP, though I just put it as MRI. But when we tell MRI, it is what we tell MRCP, or magnetic resonance cholangiopancreaticography. This is basically a MRI concentrated to the bile duct and the pancreas. MRI gives us good information about the local anatomy. If you want very good information about the bile duct, the pancreatic head region and these areas, then we order a MRCP. ERCP on the other hand is an interventional procedure. In ERCP, endoscopy is done, the opening of the bile duct is identified, and sometimes the endoscopist will insert a brush or this one into the bile duct to take some biopsies. And if required, if the jaundice is too much, he might decide to place a stent to bring down the jaundice. This is ERCP. ERCP is an interventional procedure, whereas MRCP is a diagnostic procedure. Nowadays, pre-operative stenting, earlier which we used to do, if the patient had severe high obstructive jaundice, we used to place a stent so that his jaundice comes down and we can operate in a much in a stage where the jaundice is less. Now, pre-operative stenting is not very much preferred. Even when the jaundice is quite high, we prefer to operate directly because bile duct is a very sterile area. So, if you introduce a stent, it leads to infection. So, the role of ERCP in pancreatic cancers is coming down. Whereas MRCP has got a definite role. Like CT scan, if we need more information, MRCP gives us much more anatomical this one of the local area. So if we need a lot of information about the local area, we get a MRCP done.
So the next question, acute pancreatitis is quite painful. How big is pain as a symptom in pancreatic cancer? How is prognosis and survival time after Whipple surgery?
Yes. See, one thing about pain, it is the pancreatic cancer produces one of the worst pains which can be imagined. We have patients in the world shouting out of pain who are unable to lie down. Most of the patients will be sitting up and clutching their abdomen. This is very typical of pancreatic type of pain which we see in acute pancreatitis also. The pain here most of the time is because of the inflammation and infiltration of the nerves around the celiac plexus. The celiac artery comes very close relation to the pancreas, and the celiac plexus of nerves is very close by. And when these nerves are infiltrated, it leads to very severe pain. But what we have seen is that when pain is a very important pain is one of the most presenting feature of pancreatic cancer. Most of the time it is not operable because the cancer would have infiltrated these nerves, and most of the time we find that it is metastatic. And that is why for pancreatic cancer, when we need good relief of pain, we do a procedure known as celiac plexus block, or we inject alcohol under CT scan guidance around the celiac artery so that these nerves are blocked and the patient is not able to sense the pain. Now coming to the next part of the question regarding Whipple's operation. Whipple's operation is one of the most complex operations which is performed in the surgery. Like I said, very long operation, very difficult operation, involves many different anastomoses, many of which might give problems. Now the results of Whipple's operation varies tremendously between pancreatic cancer and periampullary cancer. Periampullary cancer is cancer within the bile duct, whereas pancreatic cancer, it is within the parenchyma of the pancreas. Now unfortunately, pancreatic cancer even after Whipple's shows a high amount of recurrence. It will vary from stage to stage. Those which have spread to the nearby lymph nodes, there is as much as a 70-80% chance of recurrence after Whipple's. But if it is in stage 1 and 2, then the recurrence chances are less. For bile duct cancer or periampullary cancers also, we do the same operation, Whipple's operation. But here the prognosis is much better. You might find that most patients are cured in this thing, and especially in early cases, as much as 70-80% or even more can get cured. But this is for periampullary cancer. For pancreatic cancer, unfortunately, the prognosis is not very good even after Whipple's operation.
So next point, chemotherapy and radiotherapy together, can it replace surgery in early stage pancreatic cancer?
No, the simple answer is no. The results which surgery can give can never be replicated by chemotherapy and radiation. They have just an additional benefit to surgery. Till now, cure is not possible without surgery. In early stages, surgery is the main treatment, and this alone can give some curative results. If you use chemotherapy and radiation, First, it is more toxic than surgery. Just because it is non-invasive doesn't mean that it is less toxic. For a patient to be able to tolerate chemotherapy and radiation, he needs to be more fit than for surgery. So that is one thing, and the results are far inferior. And generally, it is not advised for early cases to give chemotherapy and radiation when surgery is able to cure the disease. Where chemotherapy and radiation is given is more for stage 3 cancers, where surgery alone leads to poor results also. So there is some additional benefit to the tune of 15-20% by giving chemotherapy and radiation. But it is not the main treatment, it is a treatment to be used in conjunction with surgery. Sometimes you use surgery first, sometimes you use chemotherapy and radiation first, but surgery cannot be eliminated in treatment of early pancreatic cancer.
So that's all, sir. No more questions.
Yeah. So thank you very much. I hope it was useful to all of you.